Let me know when you're ready to start. All right, welcome everyone. So happy to be with you. Thank you for taking time out of your busy schedules for advancing cervical cancer care, navigating new strategies, new therapies, guidelines, and patient-centric approaches. Today's presentation is brought to you by Creative Educational Concept and is supported by an independent educational grant from Pfizer. CEC is a jointly accredited provider for continuing medical education activities for the team and by the team, including our program today. The different types of CME and CE credit available for this activity are listed here. I won't read the details, but I invite you to apply. So excited to get started here. This may include discussions of products or devices that are not currently labeled for use by the US FDA. I've been informed of my responsibility to disclose to the audience if I will be discussing off-label products or devices, and I just did that. So to ask a question, submit a question in the QA feature at the bottom of the screen. We want to hear from you. And my name is Brad Monk. I'm a gynecologic oncologist. I've been involved since I co-founded the GOG Partners Organization now 15 years ago. Many of the studies that we're going to talk about today are GOG studies. My sort of everyday job is at Florida Cancer Specialists and Research Institute, where I'm accountable for 29 research sites across the state of Florida for all tumor types. I've also been president of the Energy Oncology Cervical Cancer Committee for 11 years and the Cervical Cancer Committee Chair for the Gynecologic Cancer Intergroup. And this has really been a journey that I've enjoyed being on. These are my disclosures, but this is my message. It's independent. It is not influenced by our sponsors. And these are the disclosures of those that were peer reviewers and part of the planning committee. So we thought that that was important to note. I think our objectives are clear today. We want to talk about the evolving landscape in advanced and recurrent cervical cancer, how to use the multimodalities that we have at our disposal, chemotherapy, radiation, and now immunotherapy, and then ultimately antibody drug conjugates. I can't even imagine that when I was a younger man, I'm still a young man, but when I was a very young man, I was told that systemic therapy was ineffective in cervical cancer. That could not have been more incorrect and wrong. And what you have done over the last 20 to 30 years has been transformational and really is emblematic of what good research, strategic research through enrollment and patient collaboration can do. And so this is really exciting. And we have to individualize our treatment. What happens, as you know, is we design a trial, we do a study, we get FDA approval or EMA approval, depending on where you live, and then we integrate that into the guidelines. So we are here now at a life cycle that the studies have been well published and presented and approved, but we are also guideline focused, and guidelines also are what helps inform reimbursement. And again, if you can't get it paid for, you haven't done anything. So I was also part of the launch of HPV vaccination. It was 2006. It'll be, wow, is that 30 years next year? we have a long ways to go, though. They still are among individuals that are unscreened and unvaccinated. And even if you get vaccinated, we recommend that you continue to be screened. I'll go through the HPV vaccination guidelines. I think that's important. And when detected early, cervical cancer can almost always be cured. So if we learned anything from COVID, right? That if you want to make sure you don't die of COVID, get vaccinated. Now, there was a big controversy, and there continues to be, but COVID vaccination actually works. Unlike COVID vaccination, HPV vaccination is much safer. Okay, there's no mRNA in the HPV vaccination, it's just a protein. Okay. In fact, the harm from HPV vaccination is the syncopal event. You get an injection, stand up, you're dizzy because of the pain, and you get a skull fracture. Very different from the long potential COVID issues. And if you want to know if you have COVID, you do a viral test. Okay. So we still have a long way to go with vaccination and screening, and also in what I call underrepresented ethnic groups, which includes not only those of various races and ethnicity, but also in rural America. So Henrietta Lacks, very interesting story, the HeLa cell. She was a Black American who cervical cancer is the source of the first immortalized human cell line, HeLa cells. Really, really interesting story. She has a book, as you know, we can continue to do better among all individuals, and inclusivity and availability of not only vaccination, screening, but also treatment. So HPV vaccination, as you recall, in 2006, it was 4 types, 6, 11, 16, and 18, 2 wart-causing types, 6 and 11, and now it's 5 additional cancer-causing types. It's 9 types. It's pretty exciting that, we didn't know whether we were giving it too early, whether the immunogenicity would expire as a person got older. It's actually the opposite. The immune system is so strong in the beginning that now it's, of course, long lasting. And in fact, you only need 2 doses. It's FDA approved initially in girls, now in boys, initially up to 26, now up to 25. So it doesn't treat HPV infections, and it is enormously important. We try to message it as a cancer preventing vaccine because of the stigma that in order to get HPV, a person has to be sexually deviant or promiscuous, which is completely preposterous and false. So the guidelines here for cervical cancer screening are up. And there's a lot of discussion. Well, why do you start at 25? We start at 25 because screening can do harm. In fact, HPV infections that occur in the teenage years and even early 20s generally go away. So screening can do harm. So that's why we start at 25. The preferred is HPV testing. You can test for the virus right from the liquid vial that we obtain the PEP from. Generally, we don't discard the cytology from the liquid. We would do both, but HPV testing is preferred. And the good news is when you're double negative, the patient's HPV negative, you can avoid testing for 5 years. So I'm going to be more proactive. It's not helpful. Again, screening can do harm. What do you mean it can do harm? Well, it can lead to an excision of the cervix, which can lead to cervical stenosis and infertility and early pregnancy loss, and maybe even a hysterectomy. So these are the guidelines. They expire at the age of 65 in a low-risk patient. Several patients have a history of HPV or immunosuppression. Remember, this is a virally induced tumor about 95% of the time. I do remind you that not every cervical cancer is HPV related, and that's why screening should continue. In fact, one of the most important biomarkers in cervical cancer is if there is HPV-associated cancers, because the HPV independent cancers have a worse prognosis. We updated the staging system in 2018. What does that even mean? That means that obviously there are 3 categories in the 1B category, less than 2, 2 to 4, and greater than 4. It also means that radiologic imaging can now be integrated. And it's the same for endometrial cancer. So a 3C1 in endometrial cancer is pelvic node, and a 3C2 is aortic node. It's the same. So we've tried to harmonize it. The reason we didn't use imaging before, because imaging was not widely available around the world, and obviously this is a global cancer, but we wanted to sort of get beyond that and do what the science really demanded, which is using the imaging, which is now a routine. So I thought we could kick off with a case. The average age of getting cervical cancer is 49 to 50. This particular woman was 58. The most common cause of symptom of cervical cancer is discharge and bleeding. Obviously, in the postmenopausal bleeding scenario, it could be an endometrial cancer or a cervical cancer. Unfortunately, she has been had health insurance off and on. She's tried to do the best she can, but things happen. And so the first thing that we do when we see a patient is take a history. Second thing we do is do a physical examination. And then we do appropriate tests such as imaging or a biopsy. And that's what she had. She had a biopsy and imaging, and she had a 6 centimeter, pretty dangerous cancer spread into the paracervical soft tissue, which some people call parametrium, not to the side wall. So this would be a stage 2B cancer. The first thing that patients ask is, well, when are you going to do my hysterectomy? And it's so tangible to cut out the cancer, but when it spread beyond the cervix, probably not the right treatment. And so here would be the choices, radiotherapy, chemotherapy, or a combination. Immune therapy, because immune therapy, we're going to talk about it, pretty exciting, or a clinical trial. I didn't even put hysterectomy there, okay? It is so wrong to do a hysterectomy. Why? Because she's still going to need radiation and chemotherapy, right? So if I look here and see what the responses are, I'm glad that and again, we've come to the point where we were guideline based, and I'll show you right now that chemotherapy and radiation has been around since 1999, and in fact, it was so dramatic, this recommendation in 1999, that the National Cancer Institute put out a clinical alert. There were several papers in the New England Journal and other high impact journals. And the NCI said, look, this is a big deal, and patients should get chemotherapy and radiation. And that's what you have here. This is the NCCN guidelines, which were just updated, I think, in February. And you can see that external beam irradiation plus concurrent platinum-containing chemotherapy and brachytherapy. Now, you can add immunotherapy to that, and I'm not going to get into the confusing staging because the study was done with the old staging, but the new staging is here. But pembrolizumab is indicated, and I'll show you if there's bladder and rectal involvement, sidewall involvement, or ureteral obstruction, okay? You can use it in a patient that has positive nodes, which this patient didn't, but it's a category 2B. So there's really no way that this patient should be considered for chemotherapy and radiation and immunotherapy. So it should be chemo RT together. Her cure rate, interestingly, is probably 90% in skilled hands, maybe even better. So this is the trial, this is what I was talking about in 1999, chemotherapy and radiation. The control arm was hydroxyurea with radiation. And then in the platinum was platinum 5-FU and hydroxyurea, and then platinum alone. And you can see that the two platinum arms were the same, so we used platinum alone. And this has been widely adopted around the world. And there's been some confusion, because if you look at prostate cancer in the same part of the body, you really don't need brachytherapy. You boost the prostate. Not in cervical cancer. The cervix can be cannulated with a radioactive source, and really vastly improves the cure rate. There are a few patients that can be cured without brachytherapy, but it is reckless and inappropriate. Now, brachytherapy takes advanced skill, and that's part of the issue. And you can see that in the middle bullet point that we're getting better, but there's still maybe 15% or so of patients that don't get brachytherapy, quite frankly, because either people don't know or they don't have the skill set. So she undergoes a surgery, which I would argue is probably not the right choice. And again, it's just sort of, it's tangible. And then she gets the chemotherapy and radiation that she needs. And ultimately, recurs in that operative field. Now, would she have not had a recurrence if she would not have had the inappropriate surgery? That's unknown. You can spread the cancer with surgery in this setting, particularly if it's done robotically. This patient had an open surgery, but now she has cancer in the radiated field. What does that mean? It means she's going to die. Okay. Unless you could do a pelvic exoneration if it's just in the cervix, but that's not the situation here. So again, it's tempted to cut it out again. And surgery in a radiated area is even more complicated. And we've studied some chemotherapy, platinum taxane, or non-platinum. So if you like platinum taxane, you could say A. Bevacizumab was a study that I had the pleasure of being associated with. It was the first targeted therapy approved in cervical cancer with platinum taxane in 2014. You could even add platinum taxane in immune therapy, that would be C, or you could do an antibody drug conjugate. I didn't talk about the clinical trial option in the beginning because there are no clinical trials, and the reason there are no clinical trials in that newly diagnosed 2B cancer is because the cure rates are so high. So then there's really not much of an unmet need. Here there is a important opportunity for a clinical trial. There still are no clinical trials in this setting, at least today. And so the real option would be probably chemotherapy and immune therapy. And if you wanted to add bevacizumab to that, and what we would call quadruplet therapy would be a risk assessment of the risk of fistula. If the cancer is close to the bladder or the rectum, bevacizumab, which increases the risk of vaginal fistula, should be not included. But chemotherapy, immunotherapy is what should be used. So I'm now going to talk you through a couple of clinical trials. Keynote-18, or again, I talked about the GOG. This is a GOG 3047, also European study. The European network's called Care.Get. So the sponsor names it Keynote-18. We name it 3047, and the Europeans name it CX11. And it basically was chemotherapy and radiation with or without pembrolizumab in those locally advanced cervical cancer cases where surgery was not indicated. Now, this is a high-risk population, patients with positive nodes or this pelvic sidewall